So I think maybe we can just wrap up to get you input in terms of for prostate cancer, what do you think is coming, what excites you, in terms of in the near future, anything you think is promising that may potentially change the landscape. We will talk about using this agent early on. If there's other maybe emerging immunotherapy, cancer vaccine you are excited about.
So I'll start first. I think the biggest change for me and excitement has been that the ADT alone is no longer a good standard of care. Most patients should be getting ADT plus ARPI. That's been a good, longer, more durable responses, good quality of life, generally speaking, with most of the ARPIs or even ABI. I think the diagnostic tools, the PSMA scans have been helpful in identifying truly metastatic patients. In treating people with oligometastatic disease, they've had some really good salvages. That's been very exciting. For me, what I'm excited about is to see what immune therapy can deliver. Obviously, it's very, very early and nascent, and we were briefly talking about CAR-T. Maybe that'll be something that'll come through for prostate cancer as well.
Jad?
Yeah, so doublets, they're still very underutilized in the world and in the US. So I think one big movement should be you have them, they're available, they're safe, they're more and more tolerable with newer drugs, and just getting the message out there, using them for mostly every patient. And then from a clinical trial perspective, some of these T-cell engagers and bispecific cell therapies that you're running at Moffitt that you could talk to us a bit more about are exciting and going to be more tolerable to patient with prostate cancer that are generally more elderly, and could be another. We were talking about the limited tools when you have someone who's young and they're going to be living with this disease, unfortunately, for many years, but at one point you unfortunately run out of options. So these could be more end-of-line approved option that with time will start moving them back to the front line, and like we're doing with other currently approved therapies.
So the disease that comes to mind when Dr. Malhotra mentioned is multiple myeloma. So CAR-T therapy, and then these patients can go off treatment for a period of time. I mean, a year or perhaps more. So hoping something similar in prostate cancer, and also with radioligand therapy, such as Pluvicto moving early, hopefully we'll have data that they can get it in the castrate-sensitive phase, where they can be off treatment, or perhaps we can keep them off therapy for a period of time to have improved quality of life. Molecular studies, immunotherapy, and such, I think those are very exciting. Hopefully will turn into real-world treatment.
Yeah, I think a T-cell engager is really exciting area to me as well, because we know there are phase 3 trials coming with Amgen's anti-STEAP1, J&J's anti-KLK2. The STEAP1 data was published in Cancer Discovery, 2 years ago. Very rapid PSA response, and then more than close to 30% has durable response as well. I think just like you mentioned about multiple myeloma, they do CAR-T followed by T-cell engager. So in prostate, we could do radioligand therapy followed by T-cell engager. The T-cell engager you use radioligand debulk the tumor, then use the immune system to consolidate as a sort of maintenance therapy. So that's what I'm really excited about. But I think the truly unmet need is the neuroendocrine, the small cell prostate cancer. So we don't really have good treatment. Even the T-cell engager target DLL3, the response is not as great as like a small cell lung cancer. So I think that's something keep in mind. Particularly, you see patients with bad genetic like TP53, loss of ARPI, monitor more closely. You don't want them to become neuroendocrine right now. Really, the treatment is limited. That's a huge unmet need. Yeah. I think nowadays with people living longer, we see more prostate cancer with brain metastasis, like undetectable PSAs. bad headaches, end up in hospital, then find out brain metastasis. We have a T-cell engager trial because the potential neurotoxicity, the brain MRI is part of the screening. We actually have 5 screen fails. It's just because asymptomatic brain mets. Yeah, so it's a disease, it's evolving. When you treat, the cancer becomes smarter, but this is it's exciting. We have more treatment available, but hopefully one day we can come up with a cure. I think the other nice thing about prostate cancer, you have this stage called biochemical recurrence. When you know there's cancer there, but it's only detectable by the marker. That's really the best stage you can cure the cancer. I think that's probably the stage the immunotherapy will be really the go-to strategy, to get rid of the cancer. So hopefully we can achieve that one day.